Hello, Bacho. I am Dr. Sakshi Arora Hans, your OBGY faculty at Maro, and today I have brought NEET-PG 2025 OBGY questions recall for you. Now, before we deep dive into the questions, let's have an overview of how the questions were asked in Obs and Gynae. See, if you ask me how was Obs and Gynae overall, I would say the paper was fantastic with lots of questions on Obs and Gynae, clinical questions on Obs and Gynae, and I can assure you, each and every question you've done in Maro, whether it was your main videos, revision videos, MCQ discussion videos, these things have been covered somewhere or the other. And these are the topics where we were supposedly thinking the questions are going to come from, right? So the questions were from easy to moderate category, and yes, the only thing what the questions reinforced was what I have always been telling you, concepts, bacho. That is just one thing which you have to build, and that is concepts, and that is what we at Maro stress at. So if your concepts are good, these questions were nothing but just a piece of cake for all of you. So question number 1, which was related to toxoplasma, but actually not related to toxoplasma in pregnancy. This was a very, very simple question which tested your microbiology knowledge, your immunology knowledge. Let's look at the question. A 30-year-old pregnant female with history of enlarged inguinal lymph nodes and toxoplasma 5 years ago was tested positive for IgG to toxoplasmosis, right? She should be. Now, even before I tell you the answer to it, you should know that if IgG is positive and IgM is not mentioned, it means definitely this is an old infection, right? And that too, the patient has toxoplasma 5 years back. So obviously it won't have any effect on current pregnancy. So she should be counseled that the fetus is at risk of severe infection and pregnancy should be terminated. Absolutely not. She should be counseled that there is no risk to the fetus and pregnancy should be continued. Absolutely. She should be started on treatment immediately. No. She should undergo amniotic testing to confirm infection to the fetus. Absolutely not. Right? So answer to this question is option B. Now, understand that whenever there is toxoplasmosis in pregnancy and you are getting a scenario like this, that IgG is positive and IgM is negative, only thing what you have to do is you have to reassure your patient that this is a past infection, right? Now, for present infection, what you should get for present infection, IgM should be positive, right? Now, once IgM is positive, you are going to look at the gestational age. Now, once you look at the gestational age, depending upon the gestational age, number 1, depending upon whether the fetus is infected or not, number 2, you are going to give management of toxoplasma in pregnancy. So, for example, over here I have written that if IgG is positive, IgM is negative, it means it's a past infection. That means patient is immune, no treatment required. If IgM is positive plus minus rising IgG titers, that means there is a recent infection and there is risk to the fetus. So you will have to confirm whether there is acute infection with IgG avidity testing, right? All of you know that low avidity means that there is recent infection. Now the management, as I said, is based upon gestational age and it is based upon fetal infection status. If maternal infection is diagnosed at less than 18 weeks and there is no fetal infection, right? How do you come to know about fetal infection? By doing amniotic fluid PCR, right? So if there is no fetal infection, the drug of choice is Spiramycin because it is going to reduce transplacental transmission, and Spiramycin is safe in pregnancy. It is not teratogenic. Now, if maternal infection is diagnosed at more than equal to 18 weeks, or if fetal infection is confirmed at any gestational age, then the drug of choice changes from Spiramycin to pyrimethamine plus sulfadiazine plus folinic acid, which is called as the triple therapy. Right? You have to avoid pyrimethamine in first trimester because it has got teratogenic risk, and you have to continue this pyrimethamine plus sulfadiazine combination till delivery. Right? Now, how do you confirm fetal infection? As I said, for confirmation of fetal infection, you have to do amniotic fluid PCR. And if it is positive, you have to go for triple therapy regardless of the gestational age, although pyrimethamine is avoided in first trimester. Duration, you have to continue this treatment till delivery, and while the patient is on pyrimethamine plus sulfadiazine, you have to monitor CBC and you have to monitor the renal function. Now, you always you have to tell a pregnant female that she has to avoid eating raw and undercooked meat. She has to, because you all know that Toxoplasma gondii infection is carried through cat feces. Right, so that is why raw and undercooked meat has to be avoided. They have to wash fruits and vegetables well, and they have to avoid handling cat litter. Or if they are handling cat litter, then they have to use gloves. Right, and that is what I have written over here, that you have to confirm whether the fetal infection is present or not. If fetal infection is present, or if gestational age is more than equal to 18 weeks, the drug of choice is pyrimethamine plus sulfadiazine plus folinic acid, which is called as triple therapy. If gestational age is less than equal to 18 weeks and fetal infection is absent, then the drug of choice is pyramycin. And if amniotic fluid PCR is positive, then again you have to go for triple therapy. Right? So this is how you have to manage toxoplasma in pregnancy. Very, very simple management of toxoplasma in pregnancy. Right? Coming to the next question, a P1L1 mother with BMI of 35 is diagnosed with preeclampsia and she underwent LSCS. What is the ideal agent for prophylaxis postpartum venous thromboembolism? Now, in the video on puerperium, where I have talked to you septic pelvic thrombophlebitis, I have told you that during puerperium, if you have to give thromboprophylaxis, you are going to give it through heparin. Low molecular weight heparin is the anticoagulant of choice in pregnancy and during puerperium. Right? Warfarin, it has to be used only in one condition in pregnancy, and that is if there is mechanical valve replacement. Other than that, warfarin is not used in pregnancy at all. So obviously, if this patient is requiring thromboprophylaxis, which she will require, why? Because high risk factors are present. High risk factors like BMI 35, that means she's obese, like preeclampsia, which again is a high risk factor for thromboembolism, and the most important risk factor is she has underwent LSCS. So the guidelines say that whenever there is, a risk of venous thromboembolism, the drug of choice, this is what Williams 25th edition is saying, that low molecular weight heparin is preferred for prophylaxis in high risk obstetric patients, including those with obesity, preeclampsia, and those undergoing cesarean delivery. Please remember, postpartum prophylaxis is typically continued for 6 weeks in women with multiple risk factors. Now, this is what I also tell you, that low molecular weight heparin is the drug of choice. Warfarin is not the drug of choice in puerperium also, because number one, warfarin is present in breast milk. It gets secreted in breast milk, although it is very less, but yes, that is there. Number two, whenever you are going to use warfarin in the postpartum period, the onset of action of warfarin is delayed, and then you will have to repeat INR monitoring to see whether the adequate INR has been attained or not. Unfractionated heparin again is not the drug of choice. Why? Because unfractionated heparin you have to give IV. Isse better hai that we give low molecular weight heparin, right? So always in the pregnancy also and in postpartum period also, you have to give low molecular weight heparin. Right? So the answer to this question was option A. Then, next question, a resident is performing a maneuver in labor room. Identify the procedure. This particular image I have discussed with you. This method I have discussed with you in your videos. I have shown you that while you are delivering the placenta, with one hand you are going to push the uterus up and above, and with the other hand you are going to give traction to the cord in downward and forward direction, and that is what is called as controlled cord traction. Right? What is the other name for controlled cord traction, beta? It is modified Brand and technique. And please remember that modified Brand Andrews technique or controlled cord traction. That is the method of delivery of placenta which has been included in active management of third stage of labor, right? So another very important point is that while you are doing controlled cord traction, just in case the cord breaks and your patient has heavy bleeding, what is the next step? Then the next step is manual removal of placenta, where you are going to take your hand inside the uterus and you are going to bring the placenta out, right? This particular method is controlled cord traction, right? Okay. Next question. A primigravida suffers atonic PPH during labor. After initial measures and medical management has failed, what is the next best step of management? A very, very important question, a very predictable question which we have been discussing in class, that AMTSL, PPH are one of the hot favorites of NEET-PG examiners. So again, and this algorithm you have done with me, that whenever we diagnose a patient with atonic PPH, always beta, the first step are 3 steps which you have to do. Number 1, you have to go for bimanual massage. Right? These 3 steps you have to do together. Then you have to start uterotonic drugs, right? And you have to give injection tranexamic acid. These 3 steps I'm going to do together. Once these 3 steps are done, this I'm going to do for half an hour. Then, and if it fails, then I am going to go for mechanical compression. This mechanical compression I am going to do with the help of Bakri balloon catheter, right? So I have to go for a balloon tamponade. If this fails, right, then I am going to go for compression sutures like B-link sutures. Then in next is compression sutures, right? And if that fails, then I go for stepwise devascularization. So this is how you have to go in the algorithm, right? So next in the algorithm is balloon tamponade. A question which they commonly ask you is that what is the maximum capacity of Bakri balloon catheter? That is 500 ml. You are going to fill it with warm normal saline, and if bleeding is controlled, very good. If bleeding is not controlled, you are going to go to the next step, which is mechanical compression, for which you will have to shift your patient to OT. You will have to perform a laparotomy. You will have to take out the uterus, and then you have to perform compression sutures, that is B-link sutures, right? Okay. Next question. A G2P1L1 suffers cord prolapse during labor. Cervix was 5 centimeters dilated and cold pulsations were felt, which means that the baby is alive. What is the next best step? Now again, as far as the management of cord prolapse is concerned, I've always told you that there are 3 basic steps which you have to do whenever you have a patient coming to you with cord prolapse. If cord prolapse happens during labor, number 1, you have to call for help and you have to prepare for delivery. That is the first thing. Again, this is an obstetrical emergency. Number 2, you have to relieve the pressure of the cord. And how are you going to relieve the pressure of the cord? Either by shifting the patient into knee chest position, Trendelenburg position, or you are going to elevate the hips, or you are going to manually elevate the presenting part. You don't have to touch the cord. You have to elevate the presenting part, or you are going to fill bladder. And I am sure you remember this. I have told you that when you fill maternal bladder with 500 to 700 ml of normal saline, that is what is called as Vago's method. So your management priorities are, yes, this is an obstetrical emergency. I have to deliver the patient. I have to relieve the pressure of the cord. I have to maintain cord pulsations until delivery, and I have to expedite delivery. And when I say we have to expedite delivery, always the best thing to do is cesarean section, right? If the cervix is not completely dilated. If cervix is completely dilated, then I'm going to go for vaginal delivery, right? So this is how you are going to manage a case of cord prolapse. Now, why not the other options? Other option was wait and watch. Obviously, you're not going to wait and watch because that is going to compromise the fetus. Oxytocin is going to worsen the cord compression, right? So you have to relieve the pressure on the cord first. Push the cord back and pack. That is not recommended. You are never going to touch the cord because manipulation can cause vasospasm and that can worsen hypoxia. So you have to relieve the pressure of the cord, and to relieve pressure of the cord, you are going to elevate the buttocks, tilt the head, and you are going to fill the bladder, which is called as, filling the bladder is called as Vago's method. Right? This is what you are going to do. In this particular case, how are you going to expedite the delivery? You are going to expedite delivery by doing cesarean section. Right? Okay. Coming to the next question, a 25-year-old female has a regular 28-day cycle. Which of these hormonal patterns will be seen between day 21 to day 25 of her cycle? Now, please understand. Whenever I have taught you menstrual cycle, I have always told you that there is, the way the graphs have to be studied in menstrual cycle. If you look at this particular graph, in this graph, what you are seeing is that just before ovulation, there is an LH peak and there is an FSH peak. Not only this, LH peak is a result of estrogen peak. So there are 3 peaks which are happening before ovulation. First of all is estrogen peak. Estrogen peak is leading to LH peak, and there is FSH peak also before ovulation. Now, at the time of ovulation, corpus luteum is formed, and corpus luteum in turn forms progesterone. It forms mainly it is going to form progesterone, right? So mainly it forms progesterone. Then it forms estrogen and it forms inhibin A. Now, all of you know that progesterone and estrogen, they have a negative feedback on LH and negative feedback on FSH. Second thing which I have also told you always is that corpus luteum's maximum activity is seen on day 22 of the cycle. That means maximum progesterone is secreted by corpus luteum, maximum estrogen is secreted by corpus luteum on day 22, and because maximum progesterone is secreted by corpus luteum on day 22, minimum levels of LH and FSH are seen on day 22. So there is no doubt that if a question is asked that between day 21 to day 25, how are the levels of LH, FSH, estrogen and progesterone going to be? Progesterone is going to be maximum. Estrogen will also be high. It will not be as high as progesterone, but yes, estrogen levels, I can't say estrogen levels are low. Are you understanding the difference? LH and FSH levels are low, right? So between day 21 to day 25, there is increased estrogen and progesterone and decreased LH and FSH. That is how what you get in a menstrual cycle or between day 21 to day 25, right? Then next, identify the maneuver which is being shown in the image. Again, a very, very easy question which we've always done in class. I have always told you that if you see legs of the baby out, that means this is breech where the legs have been delivered. And I can't see the head out. What I can see is that the back of the baby is held. And you remember, I have shown you this maneuver in videos also, that once the back of the baby is held and the shoulders are being rotated, this maneuver is called as Lofsitz maneuver, which is for delivery of the shoulders. What was Morrissey-Smiley-Wheat technique? Beta, Morrissey-Smiley-Wheat technique was this one, which is also called as malar flexion and shoulder traction, where when you check that the back of the baby is anterior and you have to deliver the head of the baby, what you do is on your one hand is go inside the vagina and it will be on the cheek of the baby. Other hand is going to be on the shoulder of the baby and you are going to go for malar flexion shoulder traction, which is called as Morrissey-Smiley-Wheat technique, which is for delivery of the head when the back of the baby is anterior, right? So this is the maneuver which is Morrissey-Smiley-Wheat technique, right? What is Pinard's maneuver? Beta, Pinard's maneuver is this maneuver which is done for extended legs in case of frank breech for delivery of the legs. For delivery of the legs in frank breech, you are going to take your fingers up till the popliteal fossa, P for popliteal fossa, P for Pinard's maneuver. You are going to give a pressure on the popliteal fossa. The feet of the baby will come down. You are going to hold the feet of the baby and bring it out. That is what is called as Pinard's maneuver. A similar maneuver for flexed breech for delivery of the buttocks is groin traction, right? So this over here is groin traction. This over here is Pinard's maneuver. Both these maneuvers are for delivery of legs. One is in case of flexed breech, and other one is in case of frank breech. Right? All this we have done in class. Right? Then burn Marshall maneuver. Burn Marshall maneuver is the maneuver. This over here is Lofset's maneuver. Do you see? This is Lofset's maneuver, where the feet of the baby are delivered. You are holding the back of the baby and you are rotating it so that the shoulders come in AP direction, and you are delivering the shoulder, which is called as Lofset's maneuver. Now, look at this maneuver over here. This was what was Morrisseau-Smiley-Wheat technique. MSV technique, which is also called as malar flexion shoulder traction. Now look at this maneuver over here. In this maneuver over here, the back of the baby is anterior. I am holding the feet of the baby and taking it towards mother's abdomen. This is what is Burn Marshall technique, which is again for delivery of the aftercoming head and breech when the back of the baby is anterior. I don't want any of you to get confused between Burn Marshall and the maneuver which is shown over here, which is appearing very, very similar to Burn Marshall, right? But the catch point over here is that the back of the baby is posterior. When the back of the baby is posterior and you are holding the feet of the baby and taking it towards mother's abdomen, this is called as Prague's maneuver. Right? And always I have been showing this maneuver, and to my surprise, this maneuver was asked in the nursing exam. Right? So be very, very careful between Burn Marshall and Prague's maneuver, which appear very similar. The only difference is in Burn Marshall, the back of the baby is anterior, whereas in Prague's maneuver, the back of the baby is posterior. P for posterior, P for Prague's maneuver. There is only one maneuver for delivery of the head when the back of the baby is posterior, and that is Prague's maneuver. Right? So with this, we have revised all the maneuvers which are used in breech. Right? Now, coming to the next question, a 55-year-old woman presents with the following finding. She has history of 2 home births with an untrained tie. Which of the following ligaments would have been injured? So, pehle to bacho, please understand this image over here, which so many times comes as spotters, and in your class, I have always told you how to identify between or how to differentiate between an image of prolapse and image of uterine inversion. Whenever you see that the os is visible, that means this is a case of prolapse, uterocervical prolapse. Number 2, this question is saying that patient has history of 2 home births. Again, that is one of the reasons or precipitating factors for prolapse with untrained thigh, and the age of the patient is 55 years old. All this is going in favor of prolapse. Now, all of you know that what are the ligaments which support the uterus? The ligaments which support the uterus, I don't need to tell you, we've done so many times in class. Number 1 and the most important ligament is cardinal ligament. What is the other name for cardinal ligament? Transverse cervical ligament. And what is the other name? The other name is McInroth's ligament. Right? Then we have uterosacral ligament and the pubocervical ligament. I hope you remember how we have done it in the marrow. In marrow, we have done it like this. So we have a ligament which is connecting cervix to pubic symphysis, which is your pubocervical ligament. Then there is a ligament which is connecting it to the pelvic side walls, which is ligament number 1, that is cardinal ligament. And then we have a ligament which is connecting it to the sacrum, and that over here is ligament number 2, that is uterosacral ligament. Together these ligaments are called as triradiate ligament. Right? Now, these are the main ligaments which support the uterus. Then there is a secondary support, that is round ligament. How does round ligament act as a secondary support? Because it promotes anteversion of the uterus. Right? And a ligament which does not support the uterus, that is broad ligament. Why? Because broad ligament is just a peritoneal fold, and no organ's peritoneal fold ever supports an organ. Right? Then what are the muscles which support the uterus? I have told you, you can remember them with the mnemonic BLEST, BLSD, where B stands for bulbospongiosus muscle. L stands for levator ani muscle. Levator ani muscle, what are the parts of levator ani muscle? The parts of levator ani muscle are pubococcygeus and iliococcygeus. I hope all of this you remember. Then S stands for superficial transverse perineal muscle. right? And D stands for deep transverse perineal muscle. What are the muscles which don't support the uterus? The muscles which begin with ischio, that is ischio-coccygeus muscle does not support the uterus, and ischio-cavernosus muscle doesn't support the uterus. Which is the main muscle which supports the uterus? Levator ani muscle, and overall also levator ani is the most important support of the uterus. So over here they had given you round ligament, McEnroth's ligament, broad ligament, inguinal ligament. What is the answer? McEnroth's ligament. Clear to all of you? Okay, next question. A 55-year-old postmenopausal female, she is presenting to OPD for a routine BP checkup. Her BP is 170 by 100. She also complains of blood-stained discharge per vagina. What is the next best step? Now this patient, her BP is high, right? This patient has come to you with blood-stained vaginal discharge, which is happening in the postmenopausal age group. Right, now you tell me, high BP, postmenopausal age group, postmenopausal bleeding. All these things are raising what suspicion in your mind? Aren't they raising suspicion of something which is called as corpus cancer syndrome? Do you remember corpus cancer syndrome? Corpus cancer syndrome said that if your patient is diabetic, she has hypertension, she is obese, then there are high chances of endometrial cancer. Right? This is something which I should just keep in mind when I'm reading the options, right? Reassured that some discharge is normal at this age. Postmenopausal female may reassuring her that blood-stained vaginal discharge is normal when her BP is high, right? For that, postmenopausal bleeding, every time it's not because of endometrial cancer. But where does postmenopausal, what is the most common cause of postmenopausal bleeding? It is polyp. And after polyp, it is endometrial atrophy. But I'm not going to reassure her before I do any investigation, right? Then immediate referral to cardiologist to control the BP, immediate pelvic examination, TVS and pap smear. Absolutely right. Because I want to do a TVS to rule out, why I want to do a TVS? To rule out a polyp. I want to do TVS to measure the endometrial thickness, because if endometrial thickness is more than equal to 4 millimeters, I'm going to go for endometrial biopsy, right? And I am doing pap smear. Why am I doing pap smear? Because the most common cause of PMB in India is cancer cervix, right? So if this patient has come to me, I should do a pelvic examination, I should do a TVS, and I should do a pap smear. Definitely I'll be referring to her to a cardiologist, but not before I am satisfied and fully convinced that my patient doesn't have any cancer, right? Before that, I'm not referring her to a cardiologist, right? And obviously, I'm not going to do hysterectomy based on these findings immediately. So the answer over here, common sense, as a doctor, as a medical professional, definitely the answer comes as option C. Next question, the hysterectomy specimen of a 65-year-old patient is shown. What is the most likely diagnosis? Now, is it a fibroid? Absolutely not. Is it an endometriosis? Are you going to get any growth like this in endometriosis? No. Are you going to get a growth in adenomyosis? No. In adenomyosis, I've shown you the image. What do you get? You get a globular uterus which is symmetrically enlarged. And when you see a cut section, what do you see? You see that there are multiple hemorrhages inside the uterus, right, inside the myometrium. That and typical picture is there, which I have shown you in all the classes also, in all the marrow videos also, right? So by exclusion, my answer over here is endometrial carcinoma, right? Then a 35-year-old P2L2 woman presented with secondary amenorrhea for 1 year. She had elevated gonadotropic hormones and decreased AMH levels. Now, I don't think so that after doing so much of amenorrhea with me, so many questions related to amenorrhea with me, you should have a difficulty in this question. Always and always, I have told you that whenever the organ involved is hypothalamus or pituitary, right, what are you going to get? You are going to get hypogonadotropic hypogonadism. In other words, whenever hypothalamus or pituitary are involved, I will get decreased FSH, decreased LH, and decreased estrogen. Whenever gonads are involved, then I get hypergonadotropic hypogonadism. LH and FSH are increased, right? And estrogen is decreased. Whenever uterus is involved, LH is normal, FSH is normal, and estrogen is normal. This is something which I've always taught you. Other than this, I have taught you that you also have to remember two exceptions. What were the two exceptions which I have taught you? I have taught you that in PCOS and in androgen insensitivity syndrome, these are only two conditions in entire gynae where LH is increased and FSH is normal, amongst which PCOS patient presents to you as a case of secondary amenorrhea. Androgen insensitivity presents as a case of primary amenorrhea. From the question itself, the values of LH and FSH are telling me that LH and FSH levels are high. Normal levels of LH and FSH, they are 1 to 10 international units. That is what we normally say. And if LH and FSH is less than 4 international units, generally we consider them as low values. Right? Over here, the values are 36 and 56, which means LH and FSH are high, which means the problem is in ovary. Now, let us look at it. PCOS. In PCOS, just now I told you, LH has to be high and FSH has to be normal. It can't be PCOS. Premature ovarian insufficiency. Yes, because here the ovaries are involved. Hyperprolactinemia. The ovaries are not involved. Whenever the levels of prolactin are high, what happens? Prolactin has a negative feedback on GnRH, because of which LH and FSH decrease. Right? So the answer over here has to be premature ovarian insufficiency or primary ovarian insufficiency, which is called as POI. Another hint in the question which was telling you that this is POI is anti-Mullerian hormone levels. I have taught you in classes, in marrow videos, that normal levels of anti-Mullerian hormone are 1 to 3. If anti-Mullerian hormone is less than 1, it is suggestive of POI. And if it is less than equal to 0.5, it is diagnostic of POI. Anti-Mullerian hormone levels more than equal to 3 are seen in PCOS. Anti-Mullerian hormone is a hormone which is secreted by the granulosa cells of the preantral and antral follicles. The more are the follicles, more will be the levels of anti-Mullerian hormone. Fewer are the follicles, few will be the level, lesser will be the values of anti-Mullerian hormone. Primary ovarian insufficiency or premature ovarian insufficiency basically is the new name for premature menopause. That means menopause which is happening at less than 40 years. So this female basically is having menopause at 35 years. That means this is a case of premature menopause. Right? So this is your diagnosis. So diagnosis ban gayi. Now what about the management? Management depends upon the complaint with which the patient is coming. If a patient of POI is coming to you with hot flashes, right, obviously I have to give her HRT, and this HRT should be estrogen plus progesterone HRT, which I'm going to continue till the age of normal menopause. And if she comes to me with complaint of secondary infertility, then in that case, I'm going to do IVF with donor eggs. Right? Please remember, normally in a case of menopause is a clinical diagnosis. You don't need to check LH-FSH values for a menopausal female. But premature menopause is a lab-based diagnosis where you have to check her levels of FSH twice. Right? Okay. Next question. This question, beta, is a direct repeat from the INI set exam. INI set May exam had the exact same question, which said a 65-year-old woman presents with abdominal swelling and discomfort. Ultrasound shows ascites and multiloculated cystic swelling with papillary projections. Now, please remember, whenever you are getting an adnexal mass in a female, the investigation of choice for adnexal mass always is ultrasound. And on ultrasound, if it is bilateral, neutral, or if the mass has a solid consistency, variable echogenicity, or if there is presence of septa or papillae, if there is increased vasculitis, if your question says that there is ascites, enlarged lymph nodes, matted lymph nodes, or if the size of the tumor is more than equal to 10 centimeters, then I suspect malignancy. The hints in the question which were telling me that it is malignant is ascites, papillary projections. So I know I am dealing with a malignant mass. Right now, amongst all the ovarian cancers, which is the most common ovarian cancer? Most common ovarian cancer is the epithelial variety. In epithelial variety, what is the tumor marker? Tumor marker is CA125. Now look over here. What is the question saying? Question is saying CA125 levels are 1035. If they are more than 35 in a menopausal female, I take it as high. This is 1035. That means this is an epithelial ovarian tumor. Out of the options which were given to you, granulosa cell tumor is not an epithelial ovarian tumor. It is a germ cell tumor. And the tumor marker for granulosa cell tumor is inhibin. Right? Then Sertoli-Leydig cell tumor. Sertoli-Leydig cell tumor is an virilizing tumor of the ovary. Right? Then immature teratoma. Immature teratoma again is a germ cell tumor. Right? And germ cell tumors, their most common age group is 10 to 30 years. 65-year-old female with CA125 levels raised, the answer has to be serous cyst adenocarcinoma. Right? Many of you get distracted, right? Or you get tricked by this word multiloculated, right? Because usually serous tumors are unilocular cysts and mucinous tumors are multiloculated cysts. But that is usual. That's not mandatory. And this is something which I've explained to you in the INI set question as well. So definitely the answer to this question is serous cyst adenocarcinoma. Right? Coming to the next question. A 45-year-old woman presents with delayed cycles and heavy bleeding for the past year. 45-year-old female, delayed cycles, heavy bleeding. Ultrasound shows endometrial thickness of 16 millimeters. What is the next best step? Now, please understand. When you have a perimenopausal female means a female, an age group which is 4 to 5 years before menopause. Please remember, in India, any female who's more than 40 years is considered as perimenopausal, and worldwide, I have told you, any female who's more than equal to 45 years is considered as perimenopausal. And this question we have done so many times in class, in marrow videos, in test and discussion videos. Whenever there is a perimenopausal female and she comes to you with bleeding, how do you proceed? Number 1, you have to do UPT. Number 2, you have to do TVS. And number 3, irrespective of TVS findings, you have to go for endometrial biopsy. Absolutely mandatory in all perimenopausal female. The other name for endometrial biopsy is endometrial sampling or endometrial aspiration cytology. What instrument do you use for doing endometrial biopsy? In India, we use Karman's cannula, and abroad we use a Vabra aspirator or a Pipel to do endometrial biopsy. Endometrial biopsy is also called as endometrial aspiration cytology or endometrial sampling. So over here, my question answer is endometrial biopsy. Please remember, if this would have been a reproductive age female. In reproductive age female, endometrial biopsy has to be done if a female has risk for endometrial cancer. For example, if she's obese or she has PCOS or she's on tamoxifen therapy, or on ultrasound if endometrial thickness comes out to be more than equal to 12 millimeters, or if there is AUB which is unresponsive to medical management. But when it comes to perimenopausal females, you have to do endometrial biopsy irrespective of her ultrasound findings. As I said, for endometrial pathology, investigation of choice is endometrial biopsy, endometrial sampling or endometrial aspiration cytology. And Gold standard is fractional curettage plus hysteroscopy. If you have to choose between fractional curettage and hysteroscopy, your answer always should be fractional curettage. In case of postmenopausal females, you have to do endometrial biopsy only if endometrial thickness is more than equal to 4 millimeters. Now, in this case, when you are getting delayed cycles, heavy bleeding, 45-year-old female, what is the most common thing what you are suspecting to come on endometrial biopsy? I am suspecting that when I will be doing endometrial biopsy, I can get a report as Swiss cheese appearance. Swiss cheese pattern. Swiss cheese pattern means that my patient is having an ovulatory cycles. You all know that near menopause, a female has anovulatory cycles, right? And here the chances of malignancy are only 1%, right? And in this case, this condition is called as metropetia hemorrhagica, or beta it is called as Schroeder's disease. Right? In this case, my management is progesterone, right? Or I am expecting that on endometrial biopsy, I may get endometrial hyperplasia without atypia. If I'm getting endometrial hyperplasia without atypia, chances of malignancy are 1 to 3%. Again, my drug of choice is progesterone, which I have to give for 6 months, and then I have to go for repeat endometrial biopsy. And if the report says endometrial hyperplasia with atypia, then in that case, the chances of malignancy are 8 to 30%. And in this case, my next step, they ask you what is the next step. Next step is fractional curettage plus hysteroscopy. But if they ask you what is the best management, obviously best management in this case is hysterectomy, total abdominal hysterectomy. So that all depends upon the further question. But as of now, the question was only limited to this, that what is the next best step? Next best step is endometrial biopsy, right? Then, what is the order of closure in mediolateral episiotomy? Now, I am sure all of you remember that I have taken a model in marrow, and with the model, I have showed you that how you have to repair an episiotomy and the order in which you have to repair the episiotomy. The order is you have to repair the mucosa, then the muscle, and then the skin. Very, very easy question, practical question, and all these practical questions we have done through models and through, all the practical aspects in marrow, and I'm sure you remember this. Next question. A 28-year-old female who's diagnosed with cancer cervix presented with hydrouretronephrosis. Again, a question which I commonly keep saying in the class, that this question I expected a more difficult question on cancer cervix. This is the most easiest what could be given to you in cancer cervix. And always I tell you, beta, that I want you to remember every stage of cancer cervix. But when it comes to overall gynae, and if you are not remembering, unable to remember every stage in every cancer, then you should at least remember stage 3. And if you have you pay attention to what I say in class and in marrow, I have told you stage 3 of cancer cervix. What does that mean? Stage 3 of cancer cervix means that lower 1/3 of vagina is involved. 3A means pelvic side wall not involved. 3B means pelvic side wall involved. And common sense tells me if pelvic side wall is involved, definitely ureter will be involved. How is the ureter placed? Ureter is placed like this. If this over here is the pelvic side wall, and these are the ligaments which surround the uterus. The ligaments which surround the uterus, what are they called as? Together, the name which is given to them is parametrium. Right? And this over here is ureter. So when I'm saying that the cancer has spread from the cervix, right? So the cancer has spread from the cervix to the pelvic side wall, definitely ureter will be involved, right? And that is why in stage 3B, either you say pelvic side wall involved, or you say there is hydroureter or there is hydronephrosis, right? So it has to be stage 3B. Right? Next very important question. What is the investigation of choice to know that the parametrium is involved? MRI. Please remember that. What is the investigation of choice to know that the kidneys are involved? CT scan. CT scan will tell you that kidneys are involved in cancer cervix. What is the investigation of choice to know that the lymph nodes are involved in cancer cervix? Lymph nodes ke liye, it is PET CT. Please remember, three very, very important things. In stage 3C1, pelvic lymph nodes are involved. In stage 3C2, para-aortic lymph nodes are involved, right? And in stage 4B, superficial inguinal lymph nodes are involved. So I want you to remember this thing, right? Then, next very important thing, a G2P1 female presented with history of previous cesarean section in active labor. During trial of labor, there was fetal bradycardia and maternal tachycardia. Persistent suprapubic pain between contractions. On examination, cervix was 8 centimeters dilated, vertex was at -1 station. What is the next best step in management? First of all, tell me, what is your diagnosis? We have done questions similar to this in our test and discussion. Test and discussion videos mein I have taken up questions on scar rupture and scar dehiscence. I hope you remember I have told you that when all the layers of uterus are ruptured, then it is called as uterine rupture. So if this over here is endometrium, myometrium and serosa, right? So this yellow colored is endometrium, this is myometrium, this is serosa. When all three layers are ruptured, then it is called as uterine rupture. When only the myometrium and endometrium are ruptured but the overlying serosa is intact, it is called as scar dehiscence. Now, I have always told you that whenever they have to ask you a question on scar dehiscence or on scar rupture, this is one typical history which they are going to give, that it was a scarred uterus. Over here, they made the question very easy by saying it was previous cesarean section scar. They could have given you a myomectomy scar. They could have given you a hysterotomy scar. So, any kind of scarred uterus, patient in labor, presenting with fetal bradycardia and maternal tachycardia. Now, this is the reason why whenever you are doing VBAC, I have told you that whenever you try to do vaginal birth after cesarean section, there are three things, beta, which you have to monitor. You remember what I have told you? Number one, you have to monitor maternal pulse rate. Why do you have to monitor maternal pulse rate? Because maternal tachycardia happens in scar dehiscence, right? So in scar dehiscence, you will get maternal pulse rate increased. This happens in uterine rupture also. In uterine rupture also, you will get tachycardia, but along with tachycardia, there will be hypotension. That means your patient will be in shock, right? So whenever you do VBAC, you always monitor maternal pulse rate. Number two, you do a CTG. Why? Because the first finding on CTG which tells you that there is a scar dehiscence or there is a uterus is about to rupture is abnormal CTG findings. Initially, there is a fetal tachycardia followed by a fetal bradycardia. So CTG changes are something which tell you that the uterus is about to rupture. And the third thing which tells you that the uterus is about to rupture is scar tenderness. So all these three things are present in this patient. There is maternal tachycardia, there is fetal bradycardia, and there is scar tenderness. All these three things are telling me that the uterus is about to rupture, that there is scar dehiscence. And whenever I'm suspecting that the uterus is about to rupture, immediately I have to stop the vaginal delivery and I have to go for LSCS. Now, why is it, beta, that it is not a case of uterine rupture? It is not a case of uterine rupture because they have not mentioned that the mother is in shock. Number two, in uterine rupture, the fetus would have come out into the peritoneal cavity. So the question would have said that fetal parts are palpable per-abdominally, which they have not given. Third very important point. Now, in case of scar dehiscence. You can feel the head of the fetus pervaginally. So fetal station can be felt pervaginally. But in case of uterine rupture, there is loss of fetal station. Right? You will no longer be able to feel the fetal head pervaginally because the entire fetus is lying in the peritoneal cavity. Right? So this definitely is a case of scar dehiscence and you have to go for emergency cesarean section. So this table over here is showing you the differences between scar dehiscence and scar rupture, which I told you just now. When there is uterine rupture, you can't say that now I'm going to do an emergency cesarean section. Cesarean means you're opening the uterus and rupture means uterus is already opened. So whenever it's a case of uterine rupture, you have to resuscitate the mother and you have to do a laparotomy followed by repair of the uterus. And if it is a case of scar dehiscence, that is the uterus is about to rupture, then you have to go for immediate cesarean section. Clear? Okay. Next question. A primary gravida was prescribed Pritchard's regime to manage preeclampsia. Again, a question which is anticipated, a topic from where we expected the questions to come, and that is PIH and Pritchard regime. All of you know that the loading dose in Pritchard regime, you have to give IV plus you have to give IM. IV you have to give 4 grams, 20% solution, and IM you have to give 10 grams, 50% solution. They are asking you the total loading dose of magnesium. Total loading dose of magnesium is 14 grams. Please remember that when you are giving the loading dose of magnesium, you do not check the renal function. That means the loading dose of magnesium sulfate can also be given to females of renal failure. Yes, when I'm not checking the renal function, I don't know whether she has renal failure or not. But when you have to give the maintenance dose, which you have to give after every 4 hourly, and that is only IM which you have to give, which is 5 grams 50% solution in alternate buttocks. 5 grams 50% solution in alternate buttocks. And till when do you have to give beta? You have to give it till 24 hours after delivery or till 24 hours after the last seizure, whichever incidence is happening later. Right? So this is how you have to give Pritchard regime. But when you are giving maintenance dose, then definitely you have to check the renal function. There are 3 things which you check before you give the maintenance dose. What are those 3 things? Number 1, you have to check the respiratory rate. Number 2, you have to check for deep tendon reflexes. And number 3, you have to check for urine output. Clear to all of you? Okay. Next question. A primary gravida at 37 weeks presents with decreased fetal movements for 1 day. Right? NST showed 1 acceleration in 20 minutes and no decelerations. Now, all of you know that whenever a female comes to you with decreased fetal movements and they ask you what is the next step, best answer is modified biophysical score, which I have taught you. In modified biophysical score, what do you do? In modified biophysical score, you check the NST plus you check amniotic fluid index. NST is going to tell you about any acute hypoxia which has happened with the fetus, and AFI tells you about any chronic hypoxia which has happened with the fetus. If modified biophysical score is not given in the options, then I go for NST. And how do you do NST? NST has to be done for 20 minutes. In 20 minutes, if you are getting 2 or more than 2 accelerations, then it is called as a reactive NST or a negative NST. A reactive NST or a negative NST means that the fetus is well. Right? But on the other hand, if you are getting less than 2 accelerations in 20 minutes, then you have to repeat NST for 20 more minutes. That means for total 40 minutes, you have to do NST before you say to the patient that it is a non-reactive NST or a positive NST. This is again one area of confusion with all of you. Please remember, a reactive NST is called as a negative NST and a non-reactive NST is called as a positive NST for any fetal problems. Right? So over here they are saying 1 acceleration in 20 minutes. 1 acceleration in 20 minutes. Am I going to induce labor immediately? No, because NST is only a screening test. If I am getting a non-reactive NST, it should be followed by biophysical score, which is a diagnostic test. Right? I have to continue NST for 40 minutes. Yes. Do an emergency LSCS, instrumental delivery. No. Never am I going to do management based on NST. Why is that, beta? Because as I said, NST, a non-reactive NST is called as a positive NST. Now, what do you mean by that? When the NST is coming non-reactive, NST is telling me that there is some problem with the fetus. But please remember, the false positive rate of NST is very high. What do you mean by that? Falsely, NST tells me that there is a problem with the fetus. Actually, fetus doesn't have any problem. But falsely, NST is telling me there is a problem. Right? And that is why we don't believe NST so much when it comes to be positive. Whenever NST comes to be positive, it has to be followed by a diagnostic test, and the diagnostic test is a biophysical score. Are you understanding? On the other hand, a negative NST means a reactive NST. नेगेटिव या रिएक्टिव एनएसटी का क्या मतलब है? नेगेटिव और रिएक्टिव एनएसटी मीन्स बेटा दैट द fetus is normal. NST is saying that the fetus is normal. Now, false negative rate of NST is very low. That means, what do I mean by this statement? False negative. False negative means कि actually fetus is having a problem, but NST is falsely telling me that no, everything is okay with the fetus. Such kind of situation doesn't happen with NST. If NST is saying fetus is normal, we take it as the fetus is normal, because the false negative rate of NST is very, very low. So if NST is saying fetus is okay, I will believe that fetus is okay. But if NST is saying fetus is not okay, I will not believe. I will follow it up with a biophysical score. Are you understanding this? And this is a type of question which they ask in INICT. Next question. A patient presents with 2 months of amenorrhea with enlarged uterus. On examination, there is darkening of areola, prominent Montgomery tubercles, linea nigra is present, and there is bluish discoloration of vagina on pervaginal examination. How would you categorize these signs in pregnancy? Please understand, any sign which is evident to the patient or which is felt by the patient only, for example, nausea and vomiting, for example, fatigue, for example, increased urinary frequency, breast changes, quickening, these are what are called as presumptive signs. But when we are talking about pigmentation changes, right, enlarged uterus, the signs which as an examiner I can see, they are called as probable signs. So over here, the question is saying enlarged uterus, question is saying linea nigra, question is saying bluish discoloration of vagina, which is called as Chadwick sign or Jacquemus sign. That means we are dealing with probable signs, right? So this is what is called as probable signs. Very, very important. What are confirmatory signs? Confirmatory signs is if the fetus can be seen on ultrasound or evidence of pregnancy can be seen on ultrasound. If you can hear the fetal heart sounds either by stethoscope or by Doppler. If as an examiner I can palpate fetal parts, or if I do an x-ray and I see a fetal skeleton, which doesn't mean that I am going to do an x-ray to see whether the patient is pregnant or not. No. But by chance I didn't know that the patient is pregnant. I did an x-ray and I see a fetal skeleton, then yes, that is a positive sign or a definitive sign of pregnancy. Definitive signs of pregnancy are never seen in pseudo-pregnancy or pseudocysis. What is a pseudo-pregnancy or pseudocysis? Pseudo-pregnancy or pseudocysis means that the patient falsely assumes she is pregnant. So these signs will always be absent in pseudo-pregnancy or pseudocysis, right? Okay. Coming to the next question, again a question which we were anticipating, something on shoulder dystocia had to come. So a 32-year-old woman with gestational diabetes with fetal macrosomia is in labor, head is delivered but shoulder is stuck even after 1 minute. That means they've given you the definition of shoulder dystocia. Now they are saying what is the sequence of maneuvers, and I'm pretty sure all my bachas have answered it correctly with the help of the acronym which we have done in class, and that is HELPER. Whenever there is shoulder dystocia, you have to follow this acronym which says H stands for call for help, E for give liberal episiotomy, L stands for legs maneuver, that is Mac-Roberts maneuver. Mac-Roberts maneuver is the first maneuver which you have to do. Now, in all these options, there was only one option in which Mac-Roberts maneuver was the first. right? So I had to take that as the answer. Then you had to apply suprapubic pressure. PE stands for enter your hand in the pelvis and rotate the shoulders. I have told you that when you are rotating the shoulders, this is two maneuvers. You can call it as Rubin 2 or you can call it as Wood's corkscrew maneuver. Then R means remove the posterior arm. It's not removing the posterior arm. Basically, you have to deliver the posterior arm, which is called as Jack Mayer's maneuver. Then R stands for roll the patient on all four limbs, which is called as Gaskin's maneuver or all four maneuver, right? And the last one in the management of shoulder dystocia is push the head of the baby back into the uterus, followed by cesarean section, which is called as Zavanelli's maneuver. So all of you know that the first maneuver which you have to perform is Mac-Roberts, last one which you have to perform is Zavanelli's, in between there is Rubin's, and then there is Gaskin's maneuver. There is no doubt about this question that the answer to this question is option D. A very, very simple question, right? Next question. A 35-year-old lady presents with amenorrhea with galactorrhea. Now, the moment you read amenorrhea and galactorrhea, I'm sure my voice rings in your ears that I tell you that this is seen in case of prolactinoma. Whenever there is a prolactinoma, patient is going to present to you with amenorrhea, galactorrhea, headache, visual disturbances. Ab yahan pe to they have given you that the patient has a pituitary adenoma. What is the most probable cause of this condition? What is the most probable cause of her amenorrhea? You all know whenever there is increased prolactin levels, prolactin has a negative feedback on GnRH, and because of which LH and FSH decrease, right? So there is decreased GnRH. That is the reason for amenorrhea in a patient of prolactinoma. I have also told you, beta, in prolactinoma, if they ask you what is the most common symptom which you get, never say it is galactorrhea. In prolactinoma, the most common symptom is secondary amenorrhea followed by infertility. Right? This is something which I've always told you. But in contrast, whenever they ask you in Sheehan syndrome, what is the most common symptom? In Sheehan syndrome, the most common symptom is failure to lactate, followed by amenorrhea. Right? Okay. Coming to the next question, a 46-year-old nulliparous woman presents with history of irregular periods and with amenorrhea for 2 months and a positive urine pregnancy test. How will you accurately assess the gestational age? Now, if you remember in the marrow videos, in your notes, everywhere in classes, I have told you that if your patient has irregular periods or if your patient is on OCPs before she conceived, or if your patient was breastfeeding before she conceived, or if your patient does not remember her LMP. In all these 4 conditions, Negley's formula is not the best method for knowing the gestational age or for knowing the EDD. In all these cases, the best method for knowing the gestational age is ultrasound, and on ultrasound, the best parameter is crown rump length. So over here, the answer has to be crown rump length. Right? Now, one thing I want all of you to understand over here. Number one, I want all of you to understand that whenever a patient is pregnant, right, she will come to you with secondary amenorrhea. What will her LH, FSH, estrogen and progesterone levels be? Please remember, her estrogen and progesterone levels will be high and LH and FSH levels will be low. So whenever a patient comes to you with secondary amenorrhea where estrogen and progesterone levels are high and LH and FSH are low, that means you are dealing with pregnancy. Number 2. If a female is conceiving for the first time and she is more than 35 years old, she is a elderly primate. Right? You call it as elderly primate. Right? So this particular case is of elderly primate gravida female. Right? So Next question. Again, this is one of those questions where the image came from directly your notes. The question said, a 30-year-old female comes to you with history of chronic abdominal discomfort for past 1 year. MRI shows the following finding. In the MRI, this is an MRI which I have showed you in class. I have done this with you in class. I have done this with you in marrow. That what you are seeing over here is that the uterus is enlarged. It is symmetrically enlarged. It is globular. Number one. Number two, I am seeing that there is increase in transition zone, right? That is what I'm seeing. I'm seeing that there is myometrial hypertrophy. So when there is myometrial hypertrophy, when there is globular uterus, when the question is talking about MRI, it has to be adenomyosis. Right? Endometriosis may you are not going to get enlarged uterus. Polyp may you are not going to get enlarged uterus. Right? In polyp and endometriosis, uterus ka size is normal. In fibroid, you get an enlarged uterus, but then in that case, uterus is asymmetrically enlarged and MRI is not the investigation of choice for a fibroid. Typical finding when they are saying that there is salt and pepper like appearance, endometrial the transition zone is becoming enlarged, it has to be adenomyosis. Please remember, in uterus MRI, this over here is white color, you will get endometrium, right? Then you are going to get myometrium. In between myometrium and endometrium, there is a transition zone, right? There is a transition zone. If this transition zone is less than 8 millimeter, it rules out adenomyosis, right? And if it is more than equal to 12 millimeters, it is diagnostic of adenomyosis. For adenomyosis, the investigation of choice always is MRI. But do I need to do an MRI always to diagnose adenomyosis? No. Because most of the times, adenomyosis is recognized as a clinical finding. On pervaginal examination, if you are getting globular symmetrically enlarged uterus, which is 10 to 12 weeks pregnant uterus size, which is tender, right? It indicates that you are looking at adenomyosis. What are the typical findings of adenomyosis on ultrasound? On ultrasound, what do you get? On ultrasound, in adenomyosis, beta, you get something which is called as Venetian blind appearance. Excellent. And you are going to get hemorrhages in myometrium, right, which will appear black, which will appear cystic areas in myometrium. They are not cysts, they are blood which is present in myometrium, because adenomyosis means endometrium present inside the myometrium. And this endometrium which is present inside the myometrium is hormonally active, right? So every month it is going to bleed. So you are going to get multiple hemorrhages inside the myometrium, and that is what is called as myometrial cyst. Right? So based on the clinical findings, based on ultrasound, I will diagnose adenomyosis. Usually I don't need to do an MRI. But if MRI is done, this is what I get, that the transition zone between endometrium and myometrium is thickened. It is more than equal to 12 millimeters. What is the management of adenomyosis? Management of adenomyosis is total abdominal hysterectomy. Another point which I want you to see over here is patient is presenting to you with abdominal discomfort. That is the kind of history which you get in adenomyosis. In adenomyosis, you get menorrhagia and dysmenorrhea. Right? Most common presentation of fibroid usually is asymptomatic. And if it is symptomatic, then the most common symptom is menorrhagia. Right? So this over here is adenomyosis, a typical picture which I have shown you, MRI in case of adenomyosis, right? So that's all with the discussion. Just one thing which I want to tell all of you is everything is going to be okay in the end. And if it's not okay, it's not the end. So don't lose hope. Your dream branch is like your life partner. the branch which you want to follow. By chance, if you are not getting that result, what you expected, that branch which you expected, don't worry, just give in one more attempt. INICT November is round the corner. I'm not saying that you are not getting selected, but don't compromise on the branch. Your branch should be your passion. If your branch is something you are passionate about, you will never ever feel that you are working too hard. And these questions which come on work-life balance, they will never come onto your mind. Like so many of you keep on asking me, ma'am, obs and gynae, how do you maintain the work-life balance? Because my passion is teaching. And because my passion is teaching, I'm never bored of my work. Same goes with all of you, right? So if by chance you don't get your expected result, your desired result, don't take it as an end. Don't be okay with that result. Work hard for 6 more months, 8 more months, and get your expected results. All the best to all my bachas. I'm sure you are going to do really well. And after your results, I will be waiting for your messages. Take care. Lots and lots of love.